Pain is an alarm. It drives the person out of his comfort zone and compels it to look for relief. But pain can be panic when it comes to be a liver pain or a chest pain. It is our prime duty to differentiate the pain of emergency to the others. Today we have brought chest pain as in topic with Dr. Ripen Gupta, Director and Unit Head Cardiology Max, Super Specialty Hospital, Saket. He is interviewed by Dr. S.K.mathur, a leading family physician. Over to you, sir.
Good evening, Dr. Ripen.
Good evening, sir.
It's nice to be with you. We have few questions to ask from you, from the expert like you, how to evaluate or how to treat a patient with chest pain. Now, the first one, assess or evaluate patient with chest pain in the clinic setting. When the patient comes, complains of pain, I would like to request you to give me the approach. How do we treat the patient with chest pain?
I think, sir, this is a very common symptom. Chest pain is one of the commonest symptoms which a patient will have.
Yeah.
So first we have to decide whether this is a typical chest pain, atypical chest pain, or a non-cardiac chest pain.
Okay.
So how we differentiate between the three? That if the patient has a chest discomfort, which is retrosternal, increases on exertion, and it is relating to the arm, so then that is practically a classical chest pain. Now, if the patient has some features of this pain, but not exactly all the features, let's say he says that pain is retrosternal, but is not relating to anywhere and no definite relation with the exertion, then we are scared. If he says pain is there, but it is not retrosternal, it is on the right side of the chest or on the left side of the chest, but increases on exertion. So if one or two features are there, then we say it is an atypical chest pain. If the patient says that he has a chest pain which has no relation with effort, it is site is also changing. Sometimes it is on the left side or the right side. And if we can pinpoint the pain, then it is not a heart pain. Heart pain is always diffuse. So if he says that, okay, he has a pain at one point in chest, so that is basically a non-cardiac chest pain. So whenever a patient comes to us in the OPD, the first thing we do is triage the patient into these three categories, whether it's a classical chest pain, atypical chest pain, and non-cardiac chest pain. Then depending upon the categories, then we can do further evaluation. Like if the patient has a classical chest pain, then definitely we have to go for a ECG, echo, and straightway angiography, because this is a patient where chances of some blockage is very high. And though this category is very least common, because classical chest pain is not very common. The commonest category is atypical chest pain, where the patient has some features of cardiac chest pain, some features are not of cardiac chest pain. In those patients, then we have to do further investigation to be very sure that are we dealing with a heart pain or not. And non-cardiac chest pain, we always try to find the other reasons, whether it is a muscular chest pain or it is due to some gastritis, because these are the two commonest differential which come to the mind whenever we have a non-cardiac chest pain.
Sir, is there any associated symptom with the chest pain like sweating, previous exertional history also should be taken into account for?
So chest pain with symptoms, with the accompanying symptoms, give us a more, you can say, surety that we are dealing with a cardiac chest pain. Let's say if the patient has a chest discomfort and he says that he has a sweating along with that, that clearly tells us that this could be a cardiac chest pain. If the patient has chest discomfort, but along with that he has some nausea, vomiting, retching, and so then we know that, okay, this could be a more of a gastric problem, may not be a heart problem. And if the pain goes from the chest and radiates to the left arm, so that is a very classical feature of cardiac chest pain. While if the pain is there and it radiates to the back also, that also can be because of cardiac chest pain. If the says that patient has a chest pain, but it is going to the leg or it is going to the head, then it is not a cardiac chest pain, because cardiac chest pain cannot go below the angle of jaw and below umbilicus. So any pain which is radiating to a area which is not substantial beyond this is not a cardiac chest pain. So associated symptoms are helpful in diagnosis.
Thank you, sir. So we have to differentiate with the typical, atypical, and other pain. So first we have to identify the patient is a typical chest pain or atypical chest pain.
Yeah.
Then the second, when we suspect a patient with a typical chest pain related to cardiac origin, what are the investigation required with this patient? How do we approach to further evaluate the patient?
Yeah. So when a patient comes with a typical chest pain, then a further short differentiation is that is it acute emergency or it is a chronic pain. Let's say the patient says that this pain is there for last half an hour and it is not going away. Then we know that we are dealing with something very serious and we have to immediately do an ECG. If the patient has a ST elevation or a gross ST depression on the ECG, then we immediately have to send the patient to a higher center for management. If the patient gives that this is a history which is there for last 1 month, 2 months, then we know that, okay, this is a stable angina patient. And here we can sit and decide about the investigations. A basic investigation is always an ECG and an echo, because we want to see the heart function. We want to see whether patient has some associated valvular abnormalities. A lot of times, the patient has a severe aortic stenosis in an elderly person, and that could be a reason for angina. He may not have any blockages. And once we've done these two investigations, let's say ECG has come normal, echo has come normal, which usually happens in a stable angina patient, then we have to decide the third investigations. If we are clinically very sure that it is a cardiac chest pain, then we should go for either a CT coronary angiography or a proper angiography. I usually prefer a proper coronary angiography because that gives us more information. But sometimes patient is reluctant to go for a invasive investigation. You can do a CT coronary angiography also in these patients, because here patient has a definite relation of pain with effort. So we want to do these tests only. I am not recommending a TMT or a stress echo or a stress thallium in these patients, because here our diagnosis is pretty made up by clinical history, because accurate clinical history can give us a 90% accuracy of diagnosis, while TMT carries an accuracy of 75%, stress echo 85%, stress thallium around 90%, and a CT angio of 95%. So if the clinical history is 90% accurate, we can only do tests which are more accurate than the clinical history, which are a CT angio or a proper angio.
Now, in the clinical settings, when we have seen the chest pain and we define the typical chest pain, what are the red flags? The emergency sign when to send the patient to a higher cardiac center, whether further tests can be done, or he can be given emergency treatment required to be intervention to be done. Right, sir?
Sir, very good question, sir. Basically, any pain lasting more than 15 minutes is either unstable angina or acute MI. So if the patient says that pain lasts for not going away, it is there for last 20-25 minutes, and it is a severe pain, then we know that this is number one, maybe unstable angina or acute MI. Immediately should refer to the higher centers. If the patient says that initially the pain used to happen only on effort, but today morning he got up and he didn't do anything and still the pain happened. Now we know that now the pain has started happening on rest also. This also means that something has happened in the heart, and this patient could be in a serious trouble if we don't do anything concrete very fast. So this is again a patient which should be sent immediately to a higher center for further management. So one is a rest angina, crescendo angina. If the patient says no, I used to initially go for a kilometer walk, and then at half a kilometer distance he started having pain. Now it starts happening at 500 meters or 3 meters or say 100 meters. Then again, this is a patient where we should move fast. So rest angina, crescendo angina, pain lasting more than half an hour is very important.
So having sent the patient, evaluated the patient, and if find that the patient is having pain for more than 15 minutes, unstable angina kind of thing, we sent the patient and you have taken the remedial measure by doing an intervention, maybe PTCA or further. So those patients who have been treated at the higher center and following in the clinic later on, how do we approach, how do we handle them? I mean, having done the acute treatment, I'm assessing the patient, diagnosing the patient, referring the patient to right center, and advice being done there, and then they come back to you.
Yeah, very good. So follow-up of a patient who has an intervention done, whether a PTC or a bypass, there are few dictums you have to remember. Number one is that all these patients will be on a dual antiplatelet, and this will continue for 1 year, whether the patient has an angioplasty done or a bypass done. So we should not stop these dual antiplatelets for this 1 year period. Patient will always be on a high dose statin, the maximum tolerable dose. So this should continue. Other medications depend upon patient's symptoms. Let's say patient has LV dysfunction, then we may give him a ACE inhibitor or a beta blocker. If the patient is hypertensive, some antihypertensives, diabetic, some anti-diabetic medications. Initially, when the patient has an angioplasty done or a bypass, we may give anti-anginals for a few weeks as a cautionary thing, but they are usually not continued, and most of the times we stop them. So giving a nitrate to a patient or as an anti-anginal doesn't make sense if patient has no angina. So that is usually stopped. But what we should remember is that if the patient comes to your OPD and he says, now I have chest pain. So first question you should ask him, is it the same chest pain with which I send you to the hospital, or it is a different chest pain? If he says it is the same chest pain, then you should start worrying again that something has happened in the procedure which the doctor has done, and he may again have a relapse, and we have to again do something further. If he says it is a different chest pain, then our worry becomes very less. So that is very important. Secondly, any non-emergent surgeries, like let's say patient requires a dental procedure or he requires an eye procedure, all this should be put on hold for at least 1 year. If it is a semi-emergency, then we can do after at least 2 or 3 months, but nothing in the first 2-3 months. If we do some procedure in the first 3 months, we have to stop blood thinners, and the patient can land up with a stent thrombosis. If the patient has stent thrombosis in the first 2-3 months, it carries a 50% mortality, means half the patient will not survive. So clearly, this thing also should be remembered. He comes to you with toothache, which is a commonest problem. So you should try to get a a conservative treatment done for them.
The post say PTCA, what are the chances of getting restenosis, and when should they go for follow up if required, and stress test or other tests required to be done? I mean, they will refer to cardiologist only, but when should be done
Yeah, so
post
very good.
PTCA follow?
You see, with the newer generation stents we have right now, the chances of reblockage is very low. It is something like 2-3%. So, and the reblockage happens in the first year of stenting, more towards the end of the first year of stenting. So, the usual protocol which some cardiologists follow, not everyone will do a testing for the patient who have a stent done, but the guideline says that at around end of 7-8 months, uh, um, if the patient is asymptomatic, you can do a stress test. Stress test could be a stress echo, it could be a stress thallium. So these are the usual two commonly used tests done for this at the end of around 8 to 9 months of the angioplasty, between 1 year, 9 months to 1 year of the angioplasty. If the patient in between have exertional chest pain, then we do some test before. Then we'll not wait for 1 year. Let's say patient starts having symptoms, then we'll do the test earlier.
Thank you, sir. This is one part. Now, another important thing for the follow up at the clinic level, the patient has come back after PTCA, he's doing fine, 1 year has passed, but they need to be controlling the comorbidities like diabetes, hypertension, lipid levels. These has to be monitored very carefully by the clinician, the physician who's observing them. And what are the criteria to be kept in mind, particularly lipids, of course, blood pressure and diabetes, the doctor will assess that. So post PTCA follow-up, comorbidities.
So I think this is a very important question again. The lipid levels are very important, and I think we are guidelines are becoming very, very clear that once you have an angioplasty done, you are at a very high risk of having a repeat procedure. So you should try to maintain an LDL level of less than 55 if we go by the European Society of Cardiology guidelines, and if we go by Lipid Society of India guidelines, then less than 40. So I try always to aim for LDL of around 40 to 50 in all my patients who have stenting done. If I cannot do that with the statins, I'll always add an ezetimibe to these patients. Let's say sometimes what happens, I give a rosuvastatin 40 mg. Patient starts complaining of body aches and pains, and we have to decrease the dose of rosuvastatin to 20 mg. Then I'll always add a ezetimibe on top of it, and mostly I'm able to achieve this goal of 40-50. I keep this in my mind that I want to have this goal in my patients. So that is the internal goal of you should keep in your mind. If you have a diabetic patient, if you have a patient who has a stent put in, or if you have a patient who had a coronary event but no stenting done, let's say had an MI but no stent put in, or who had a bypass done. In all these four subgroups, we should be very, very strict and aim for a LDL of something like 40-50.
Right. So one question about the lipid management after statin and ezetimibe. If they're not stenting, what is about PCSK9 inhibitors, which has been recently talked
Yeah,
about?
yes. A few of my patients are on PCSK9 inhibitors, and we have one available from Dr. Reddy's lab. But the problem is that it is an injectable
They're
therapy.
very expensive.
Yeah, so twice a month and something like 30,000 rupees per month. And if we are planning to put them on this therapy, it is not meant for few months. So if I discuss this with my patients, most of them refuse. So some are refused because of the cost, some refuse because of the injections to be given, and but some agree. So it is not like that. But so this is only meant for in Indian scenario, and even in European scenario or US scenario, patients where we have already tried the maximum dose of statins, maximum dose of ezetimibe, and after that the number of patients is less than 3-4%.
I think number is quite less, but due to expensive the cost also, and B, I think we can control by statin as it might. Thank you, sir. Thank you very much for your side. It is very enlightening to all of us. Any clinician sitting in the clinic will be definitely benefited by your word of advice in all aspects. Basically, what type of heart pain is typical, atypical, or otherwise, and we would like to be thankful to you for all this input. Thank you so much, sir.
Thank you.
Thank you. Thank you.